Hi, and welcome to my OCR A-level biology revision session with me, Christine. So today's lesson, I want to look at kidney disease. Let's just take a step back though and remind ourselves about ultrafiltration that happens at the glomerulus in the Bowman's capsule. We know because of high hydrostatic pressure in the glomerulus, that's going to force blood through the fenestrations between the cells, which act like a sieve. We know we've got our podocytes, which are our additional filtering system to stop any large molecules from getting through. And we know we've got our basement membrane, preventing large molecules and cells from leaving the blood. So if we have protein or blood which is found in the urine, that can signal that there is kidney damage. So we're going to look at how do we actually identify at what level that kidney damage actually is. And to do that, we look at what's called the glomerular filtrate rate. So it's a widely used measure of kidney disease and it's called the estimated GFR. Now, to understand the estimated GFR, we need to actually look at a molecule called creatinine. Now, creatinine is a breakdown product of your muscles. So you should know about creatine phosphate. Well, creatine phosphate is necessary for the production of ATP really quickly. And sometimes the creatine is broken down into creatinine, and that is then released into the bloodstream. If your creatinine levels increase in your bloodstream, your estimated GFR will decrease. That's signaling that the kidneys are not working properly. Remember, your kidneys are meant to be filtering. They are filtering out any toxic substances, and the creatinine is a toxic substance when the concentration gets too high. We need it to be released because it's an excretory molecule. It is that breakdown product of the muscles. So how does the doctor actually know what your eGFR is? Well, they do that by taking a blood sample. So here you can see what they're looking for when they take a blood sample. So they look at your serum sodium levels, your potassium levels, and your creatinine level. That will then allow them to do an estimated GFR. But we need to wait a second. We need to think back about our patient and we need to identify other factors that need to be considered. For example, what age is the patient? Because as you can see from the graph, healthy adults, as they age, their estimated GFR actually decreases, but it never decreases less than about 75. So anybody older than 70, their GFR should not be below 75. So age is a factor that needs to be taken into consideration. The next thing that needs to be taken into consideration is about whether it's male or female because of muscle mass. Because your patient, their muscle mass is going to affect the level of creatinine in their blood. If they have a larger muscle mass, as most males do, that therefore will result in an increased level of creatinine. The other thing to note is also to do with muscle mass is the race. The race of the patient needs to be taken into consideration when estimating this glomerular filtrate rate. But what we're really looking at is if the estimated GFR is below 60 for more than 3 consecutive months, that indicates that the person has moderate to severe chronic kidney disease. Now, this is something they like to do in the exam where they get you to work out through calculations or through a graph what the eGFR was and whether or not that would indicate someone having chronic kidney disease or not. So it's important we note that it's 3 consecutive months. So if they have below 60 in 1 month and then it goes above the 60, that is not going to indicate chronic kidney disease because it has to be 3 consecutive months. If the GFR goes below 15, then that will indicate kidney failure. So now, how do we treat someone who has got kidney failure? Well, we can do that with the use of what's known as hemodialysis. What they're going to use is a dialysis machine. And what they're going to do is use that machine to filter the blood. Now, normally it's usually carried out in 3 times a week in a hospital, and it takes about 8 hours, and it has to be done under medical supervision. The reason being is the blood needs to leave from an artery. So the person needs to have a needle and a tube injected into their artery so that the blood can leave. The blood then goes through the dialysis machine, and that means that it's going to flow between a partially permeable dialysis membrane. Now, this dialysis membrane is there, it's partially permeable to filter these substances, allow the small molecules through that need to be filtered. Now, the dialysis fluid flows in a countercurrent direction to maximize exchange, and it's important you note that this links to module 2.1.3, diffusion, transport of molecules. We want to get rid of urea, which is our nitrogenous waste that was made through the deamination of excess amino acids, and then that ammonia being converted by the addition of carbon dioxide into the less toxic substance urea in the liver. So this is where other topic areas come together. The other thing that needs to be exchanged is excess electrolytes. Now remember, the excess electrolytes, we're talking about that sodium, potassium, chloride ions. We need to maintain our blood concentration gradient. We need to ensure that the water potential is maintained. So when the kidneys start to fail, that will therefore mean that we're not getting rid of any excess electrolytes. So this is where it's a really fine balancing act to make sure we are getting rid of not only the nitrogenous waste, urea, but also the excess electrolytes. Now, if a patient is going through hemodialysis, they need to have a very restricted diet. Because of deamination, as I discussed before, they need to ensure they're not taking in too much excess amino acids in their protein intake. So they need to have little protein, and also they need to be careful of the salts and monitor their fluid intake, because remember, it's about that osmotic potential. So what do they need to do? Well, before dialysis can happen, first what needs to happen is a blood sample is taken, and they're going to monitor what is their current levels. Now, I've gone very basic here, and I'm just looking at urea, glucose and salt. Now, the dialysis fluid needs to be the correct concentrations so that only the waste products are removed. Therefore, the dialysis fluid should contain the same concentration as the glucose in the blood plasma. That way, ensuring that glucose is not going to move in any direction. The other thing is to monitor the salt concentration. So it depends whether or not the person needs to remove excess salt. If they do, then the dialysis fluid needs to contain less so that that diffusion occurs. But if they don't need to remove excess salt, then the salt concentration should be matched to that of the blood plasma. What we want to happen is we want the urea, the nitrogenous waste, to diffuse down its concentration gradient from a high concentration to a low concentration, therefore leaving the blood plasma and going into the dialysis fluid. Now, if the dialysis fluid and the blood plasma were just left to sit there, what would happen is the urea would then diffuse back into the blood plasma. So to ensure that doesn't happen and to maintain a concentration gradient, what does happen is that the blood plasma and the dialysis fluid actually flow in a counter current direction. Therefore, that's going to maintain that concentration gradient, allow for the nitrogenous waste to be diffused out and then removed and discarded later. So therefore, the dialysis machine is mimicking the role of the kidney in the filtering process. So what we end up going back into the patient is the filtered blood, which has been regulated. The role in which the kidney should be doing and is not able to function in is being taken over by the dialysis machine. But as it said before, it takes up to 8 hours for this to occur. So therefore, it's not a quick process. So if you are someone who has kidney failure, you therefore have to deal with the fact that you are restricted in what you can do. Now, if you were to look at other treatments for kidney failure, what could happen is what's known as a kidney transplant. Now, this is the best solution for a patient, because if this is successful, then they can live their lives as they would normally. They don't have to go to hospital 3 times a week. They don't have to sit around for 8 hours whilst the machine does the job of the kidney. What needs to happen is you need a healthy donor kidney to be connected to not only blood vessels, but also connected to the bladder with the ureter. Now, where do these donor kidneys come from? Well, these donor kidneys come from either someone who is donating their kidney, or it comes from somebody who unfortunately has deceased. So the available kidneys for transplant is very limited, because not only do we need a healthy donor kidney that is available, we need to ensure that we reduce the risk of rejection, because the rejection is really high. Remember, if we're taking an organ from somebody and putting it into another person's body, their immune system should identify this as being a foreign set of cells, and therefore that should start the immune response. Well, to prevent that from happening, what we always do is we do what's called a tissue and a donor matching to be completed beforehand, making sure that there is as close a match as possible to limit that risk of rejection. Also, the patient needs to take immunosuppressant drugs. So those immunosuppressant drugs are going to obviously suppress the immune system to reduce that risk of rejection. Well, that means that there is a risk of other infections that could obviously have a effect on the body. So it's a pros and cons you need to consider if they're going to ask you a question on this. Now, a kidney transplant is an amazing way to help somebody who's going through kidney failure, but unfortunately, it does not last forever. So it lasts approximately up to 10 years, but can be up to 50 years. Now it tends to be going up to more 20-25 years as we've advanced in our knowledge and our procedures. However, it does mean that after however long that may be, the person is needing to have that kidney removed, and then they may need to go back onto hemodialysis until another kidney becomes available. So it's important that you note that it's the pros and cons, not only the procedures, but also the pros and cons of doing this, because they love giving you a question which is looking at you evaluating the information from a stem of the question and your own knowledge. So do make sure you have a few pros for both and a few cons for both. So I hope you've liked this video, and if you have, then please do click on the like button and subscribe to my channel so I can keep making more videos and resources for you. Also, if you haven't done so already, do check out my revision platform, www.aiqchat.com.